I'm happy to bring some knowledge, hopefully, that can be of benefit. And we're going to talk about alpha-1 antitrypsin and its deficiency. And just to mention a bit about me, I'm a pulmonary and critical care fellow, meaning I'm already internal medicine trained. I'm board certified in internal medicine and in sleep medicine, but completing my training in pulmonary and critical care here at NCH. I have a special interest in pulmonary medicine and airway disease, so asthma and COPD, bronchiectasis, those are the diseases I'm looking at the most, as well as sleep disorder breathing. And I'm a Greifels Alpha-1 ambassador, so I've gone through some extra training to talk specifically about Alpha-1 antitrypsin and to treat it in the clinic. And so the things I want to go over is, what is this Alpha-1 antitrypsin? It's a new term to many possibly today. The genetics and the prevalence of it. What is the deficiency of it? How do we test? How do we screen for that? And then what are the treatments available for it? So to get a bit granular here initially, okay. So that's a picture of a protein down at the molecular structure. Alpha-1 antitrypsin is a protein that the body makes. It's known as an antiprotease. What that means is it's going to stop other proteins in the body. It's going to inactivate other proteins. It has anti-inflammatory properties. So when our body has something that's causing inflammation, it's fighting off a bacteria, it's fighting off a virus. It has its brake system once it's fighting that thing to now stop the inflammation so that it doesn't have a negative effect on the body itself. So this is that one of those molecules that really puts a stop to the damage of the inflammation. It's called an acute phase reactant. It means that we'll see it higher in the blood levels when there's some type of disease going on, when there is an infection, when there's a problem happening, produced in large amounts by the liver. And we see it in the blood, therefore, circulating to all parts of the body, and it's seen a lot inside the lung where it has such a major role. Why does it have that name, that strange name of alpha-1 antitrypsin? When we look at what proteins are in the blood, there's this method of putting things into a gel and running them under some electricity, and it separates the proteins by their size. And depending on the size, they show these spikes that we show in that bottom graph. And so that's an alpha-1 spike. Is there albumin? If you've seen that on your lab work, that's one of the major proteins the body produces. One of the next most produced ones is that alpha-1. And so therefore, that's where it gets the alpha-1. The antitrypsin, like I said, it inactivates other proteins in the body. And one of those proteins is this trypsin. So it's an antitrypsin. The name, since trypsin is not as important to its activity as the other proteases, and one that we'll talk about here in a second, some people have moved to calling it alpha-1 antiprotease instead. But that's just where the name comes from. It neutralizes neutrophil elastase. So the neutrophil is, again, another name that might be familiar from looking at the lab work you get, the standard things on a complete blood count. A neutrophil is one of the white blood cells in the body, white blood cells that fight off infection. And a major weapon that they use to fight off pathogens, to fight off bacteria and viruses and things that are causing a problem is neutrophil elastase. That's going to break down the bacteria. It's going to break down those things, to put it, in a simple fashion. But it is also going to cause damage to the lungs and to the body if we don't slow it down. And it's like a one-to-one. This alpha-1 antitrypsin molecule inactivates a neutrophil elastase molecule. So there has to be a nice balance between them. And so if we put it as these neutrophil elastase produced by the body to fight infection as these red triangles, and the green circles as this anti-neutrophil protection or the alpha-1 antitrypsin, we want to have a balance. If there's too much damage going on, so too much exposure to disease-causing pathogens or to things in the environment, pollution, smoking, and not enough antiprotease or alpha-1 antitrypsin, then we have a problem. Conversely, if the body does not produce enough alpha-1 antitrypsin, then even less insult to the body might be a problem. So one, analogy I've heard is considering these as the pyromaniacs and the firefighters. If you have a lot of pyromaniacs, then you need to have a lot of firefighters, and vice versa. It's a genetic condition. So people who have an alpha-1 antitrypsin deficiency, it's not because of something you've done wrong, it's something genetic. It's passed down from your parents. In order to be classified as having an alpha-1 antitrypsin deficiency, there has to be at least one abnormal alpha-1 antitrypsin gene. And if there is one abnormal gene, but it's not causing a problem, then sometimes you'll hear the word carrier, you'll hear the word heterozygous. So that person might not show signs and symptoms of having a problem with it, but they do have the ability to pass that abnormality on. There's different ways that genetic conditions are passed down. And so the inheritance of this is called codominant. So like, you see in these flowers on the right, if you have one parent flower that's red and one that's white, both are being expressed. So you get this mix of the both as a pink flower. In a similar fashion, the body, there's different ways that things we inherit genetically are expressed. Sometimes just one copy of a gene is going to be all that's expressed. Sometimes you need two abnormal genes. In this case, both play a role. So it's not enough to have one abnormal. Typically, people have to have two abnormal genes in order to have a problem with the disease. So there's a codominance here. One of the things you might hear clinicians that, I think they should not be saying, or alpha-1 is rare, so I don't need to test my patients. And this is not entirely true. There's an estimated 100,000 Americans that have an alpha-1 deficiency. If we were to screen the US population in general, about 15% would have an abnormal allele, meaning they're at least a carrier of having an abnormal gene. And screening COPD population, patients with COPD, then about 2% would have a severe deficiency. So the estimate is about 90% of people who have a deficiency with alpha-1 are undiagnosed. So why is that? Why is it so undiagnosed? Why is it hard to find? Well, if we look at it compared to some other lung diseases, there is idiopathic pulmonary fibrosis is a bit more common. These are ones that we think of as rare. Idiopathic pulmonary fibrosis is a bit more common, 130,000 or so Americans. Here's alpha-1. It's in second place. It's about as many as the people with sickle cell disease. It's certainly there's more people with alpha-1 antitrypsin deficiency than cystic fibrosis. And then Huntington's disease is a neurologic disease. But the difference between it and the others leads me to that next objective is how does it present? What does it look like? Idiopathic pulmonary fibrosis, we'll see on a CT scan. And with the discussion between a couple of pulmonologists over a few months, we'll have a diagnosis, if not immediately after looking at that CT scan. Sickle cell disease in a blood test, cystic fibrosis with the genetic test that's done at birth now. Huntington's disease has a very specific way people move and present it with that neurologic disease, but alpha-1 antitrypsin deficiency does not have its own way of presenting. It is a genetic condition that's predisposing to these other diseases that we have. And so the main one is going to be COPD, chronic obstructive pulmonary disease, and then the very similar asthma. People might be diagnosed as having a persistent asthma or one that has progressed to being irreversible because there seems to be no smoking history, no reason for the person to have COPD. So I do put those hand in hand in this case as refractory asthma or COPD. Bronchiectasis is a disease of inflammation airways. We'll talk here in a couple of slides a bit more about it. Liver disease, and then this rare skin disease, necrotizing paniculitis. Those are the diseases that we'll see with alpha-1 antitrypsin deficiency. So with COPD, this is the group of pulmonary diseases. You've heard the word emphysema and chronic bronchitis perhaps, and those are going to cause obstruction in how the air moves out of the lung. So air might move okay into the lung initially, but it's air coming out because of the change in both the airways and in the spongy parenchyma of the lung. That air does not move well into the lung, and then there's problems with the exchange of oxygen, with the exchange with the blood there. The risk factors of COPD are, of course, tobacco use is the most common, and so people have a longer history of smoking, cigarettes, tobacco. That's the main culprit. But other things, occupational exposures, jobs people have carried, veterans, and what they've been exposed to when they've been in service. And then, as we mentioned, genetic risk factors like alpha-1 antitrypsin deficiency. Epidemiology of COPD, it's the third leading cause of death worldwide. So it's a very major problem and one that we are very interested in addressing and treating people for. There's about 14 million people in the US diagnosed with COPD. And even so, there's still some 70 to 80% of people with COPD who are undiagnosed. By the way, do you hear me okay with the microphone?
Yeah.
Where I'm holding it? Okay, perfect. Bronchiectasis, a term you may or may not have heard. This is also a consequence of inflammation in the airway. In this case, where things get stiffer, people produce a lot of mucus, and there's a difficulty in getting the mucus out because there's also a breakdown at a smaller level of the cells, the cilia that move out mucus, move out bacteria and things that are causing inflammation in the lungs. Sometimes it's associated with a non-tuberculous mycobacteria with some certain types of pathogens or some immunodeficiencies. Cystic fibrosis causes a very bad bronchiectasis. But alpha-1 antitrypsin deficiency is also associated with causing bronchiectasis. So some 40% of people with alpha-1 antitrypsin will have bronchiectasis. And people can have bronchiectasis without COPD. So COPD is the most common manifestation, but you may see this as well. So the guidelines recommend us to test people for alpha-1 antitrypsin if they have unexplained bronchiectasis. And then liver disease, I mentioned, there is even in the pediatric population, in childhood, in babies, there can be liver failure that it can cause. But more commonly, this liver cirrhosis, so liver disease and liver failure over time. This is because we mentioned it's a protein. It's produced by the liver. The liver produces lots of proteins, and in its abnormal form, it can collect in the liver and cause problems. So it causes liver disease as well. And when you have liver disease, when you have liver cirrhosis, there's a higher chance of having carcinoma of the liver and liver cancer. Another one of these problematic statements is, I know an alpha-1 patient when I see one. So classically, what we might be taught in medical school, I heard, and what really has always been in the books, is that these are people who are younger and who have not smoked or have barely smoked. But as we'll see, that's a problematic way of thinking about it. And what it leads to is, on average, there can be about an 8 or more year delay in the diagnosis of people having a deficiency. We're missing out. We're missing out on finding out that someone has a genetic disease, and that diagnosing them would have implications for their family members, that them knowing about it, them getting tested, them being more prudent about quitting smoking if they're smoking, or moving away from anything that's causing lung damage. And as I said, the big reason for this is that it can mimic these other diseases or presents as these other diseases. And so that's why screening rather than testing when you have suspicion, it's more of a screening, even if you don't have a high suspicion for it, can be more effective. As I mentioned, there is a lengthy delay, so that's in how many years of the onset of symptoms of respiratory issues and when there's a diagnosis. And people can see 2 to 3 physicians. The average in one study was 2.7 physicians before they got a diagnosis. And the age when it was identified on average was 46. And that's a problem because people can have a significantly shorter lifespan. So if they have a severe deficiency and this isn't being diagnosed till later, then people have already seen, a decline in their quality of life. They might have not been as careful about what is affecting their lungs. So important for us to get to people earlier, to give them, management and care sooner. So just, I'm not going to go through this all the way, but as far as the guidelines, who should we screen? So anyone with symptomatic COPD, anyone who has, again, this kind of refractory asthma, it's unexplained, liver disease, that rare skin disease, necrotizing paniculitis, and family members of those who have alpha-1 antitrypsin deficiency. If someone has had, for some reason, pulmonary function testing and it's abnormal, then that also, if it's showing an obstructive disease, may mean that they should have testing. So testing one patient for this genetic disease can have an implication for the whole family. So here you have, grandma and grandpa at the top, and grandma died at age 46 from lung disease. We're seeing, someone in yellow down here in the clinic with lung disease, that theirs is not so bad, but they got tested and we find out they have this carrier MZ. But talk to them, they say, well, yeah, my uncle died of lung disease, grandma had died of lung disease. So now they're getting tested. They're telling their family members to get tested, and we discover that several of our cousins have the disease, and so on and so forth. And so it will have implications beyond the one who's getting tested. So if this person's not been tested with their lung disease and they're 70, they're 80, it doesn't seem to be progressing, there's still a reason perhaps to get tested. A complete diagnosis can be made on serum levels alone. So sometimes that's how, getting to how we test for this, it is sometimes not going to be sufficiently tested by just the blood levels, because as I said, it's a genetic disease and you might have a normal or close to normal level, but the genetic form of it is not the normal one. So we're not getting the full effect of the testing there. Another thing is acute phase reactants, a term I mentioned early on. It's elevated when there's inflammation in the body. So you might see a falsely normal level because this person was sick when it was tested. So if you haven't been tested for the genotype or phenotype, that means looking at the actual gene or the expression of it, seeing what the protein looks like is this phenotyping, then that might give a critical insight that we otherwise don't have from just the serum levels. There's multiple ways of testing for it. There's that level. Again, it might not fully detect. It won't detect carriers of the abnormal Z form of the protein. The genotyping is one that so the pros of the blood test is that it's very available. Genotyping is also quite available, and it can be just a cheek swab or just a finger prick test that can be done in the doctor's office or even a kit that's sent home. And then there's more advanced ways of testing these, phenotyping and gene sequencing, that might be needed if we're suspecting something that is more rare or there's inconclusive testing earlier on. And there's usually a chain of where you can move forward if you need that. There's multiple different forms that are abnormal, but the most common that's going to cause a severe deficiency is this Z type. And having 2 of the Z abnormal genes is when people have a severe deficiency and problems with their liver and lung. S is abnormal, but usually functional. Rarely, if you have 1 abnormal S and then that severely bad abnormal Z, then people will have disease. M is normal. M is what a normal gene is called. There's some other even more rare types that are going to be as bad as Z. And so they're all named by letter. F, S, Z is just how these genes have been named. And as I've put here, there's some that will only cause lung disease, some that'll cause lung and liver, namely, again, that Z. If we just look at aggregates of what people have who've been screened, regardless of if they have any lung disease or not, 84% of people had that normal, two copies of the normal M gene. And then if you look at the 16% of people who had abnormal, they break down into those who have 1 abnormal S, they probably have no problem at all as a result of this gene abnormality. MZ, again, 1 normal, 1 of the bad abnormal, still will usually not have a problem. And then we come down to what adds up to some 2%, 2-3% of people will have a severe form. And this is a representation, again, of people who will actually have a problem because of the deficiency. So levels that are usually protective are within this range. A normal range is all the way up above 50. If we're looking at things in 1 unit called the micromole. But you get to lower than 20 and there might be a problem, especially as you get down towards an 11, a 10 and lower. And those are usually going to be seen only with the 2 abnormal Zs or those rarer other letters, but 2 abnormal Z genes. Sometimes you get that low with an abnormal Z and an abnormal S. But again, even if you have 1 bad Z, you might be a carrier to pass on this bad Z if your partner, your spouse also is a carrier for the disease, but not yourself have an abnormal presentation. I don't need to test smokers or older patients for Alpha-1. There's a reason they have COPD. They've been smokers. They're older. There's nothing I'm going to do differently for them. No, again, there's implications for their family. If we are thinking of this as it's only those younger people, only the smokers, then we're missing. We said average age people are being diagnosed is about 46. Well, part of that is that we're not testing people often enough when they're older. And this is one of my favorite slides to show clinicians, is that this little box here in the bottom left is who we usually screen. And so on this side, we have FEV1. This is if you've had your pulmonary function test before, and it's one of the ways we say how severe an obstructive pulmonary disease is. And so the higher up here we go, the more normal the pulmonary function appears. The lower here, we're getting to a severe obstructive pulmonary disease. And on the bottom is the age. So we're usually thinking of testing these younger people who have a severe disease. But what we have here in the yellow squares and black dots are the smokers, and the black dots are the non-smokers. And all of these people have alpha-1 antitrypsin deficiency, severe alpha-1 antitrypsin deficiency. So we're getting just this many people if we're not screening more regularly rather than just who we think has the disease. So again, these are all people who had the abnormal PIZZ, so the severe deficiency. Go around this time.
I'm sorry, Doc, what was the line? What was the number on there?
Oh, under the red line, so this is where we'd start classifying people as a severe COPD.
Is that about 50?
Yeah.
Okay.
Okay, again, more than half of newly diagnosed patients in over a 3-period, 2004, 2007, were older, age of 50. Oh, I did something wrong there. Okay, well, there's no treatments for Alpha-1, so why should I test people? There are treatments, including, and most importantly, the COPD management or the bronchiectasis management. Whatever this person's major presentation of it needs to be maximally managed. Pulmonary rehabilitation, lifestyle changes, all the medications that are typically used for these diseases. And then there is augmentation therapy. So those who have a lower level of the alpha-1 antitrypsin protein can be given augmented with a form that has been collected from serum and can be infused weekly to patients who need it. So this is what the guidelines recommend as far as, so American Thoracic Society guidelines as far as the management approaches, family screening and counseling, lifestyle changes, of course, smoking cessation, exercise, avoidance of pollutants, environmental pollutants, limiting alcohol consumption, because again, liver disease is an important part of the disease, getting the vaccinations on time to avoid any of that damage that then is going to result if we haven't been protected as much as possible. And then the drug therapies for lung disorders, bronchodilators, inhaled steroids that we use for COPD, antibiotics when there is a need for those, oxygen therapy early on once people do have low oxygen levels and need that. Pulmonary rehabilitation, one of the best things we have for people with obstructive pulmonary disease and other pulmonary diseases. And then sometimes a surgical procedure, lung transplantation, lung volume reduction procedures as well. And then, as I mentioned, augmentation. So that's if we're getting to this point where we have not enough of the alpha-1 antitrypsin, and we've identified that, and there is this ongoing burden that we're going to see in everyone, but especially during disease, then we want to augment that. We can give people some more alpha-1 antitrypsin with augmentation. These are infusions. They're from pooled human plasma. So just as we collect other blood products when people make blood donations and then someone needs platelets because their blood can't clot enough, we give platelets, or they need red blood cells because of an anemia, and we give those, then this alpha-1 antitrypsin can be given as well. And the recommendations for when to give that are people who have a established airflow obstruction, so they have some obstructive airway disease, and their levels are less than 11. Or if they are starting to show worsening in their pulmonary disease at a faster rate than so a rapid decline in lung function a year, even if they started off with normal or lung function, you have to wait till these people are severe. In fact, people are going to benefit more before they reach a severe stage. There's a stronger evidence for benefit for individuals with moderate airflow obstruction, that FEV1 of 35 to 60% of predicted. And independent of the phenotype or that genotype. So even if this person had an SZ, they didn't have that ZZ that is usually going to cause the severe form. They still, based off of the level or based off of any of these above, should get augmentation therapy or should be considered to get it. There is a way to just get a home kit to test for this. So I did want to include this alpha-id@home.com, and you can have a kit that's sent home. But of course, you can talk to your pulmonary doctor or your primary care doctor and ask to have this checked as well. With any of the forms are out there. I mentioned these. I'm not benefiting from sharing these directly, but just these are commonly known to be there. And that's my last slide. So I'm, would love to hear any questions, answer any thoughts, discussion about this.
Thank you.
Thank you.
Doctor.
Yes.
George, so any connection with this to autoimmune?
It's not an autoimmune condition in and of itself, nor is there a known overlap in the genetic abnormality here and some autoimmune disease. It's possible for someone to have more than one, thing that is, be it a genetic autoimmune disease or another autoimmune disease, and this genetic abnormality can happen, and they can both, of course, affect the same liver and lung, or liver or lung, if they were to coexist. But no, there is no intrinsic tie.
Okay, because I don't think I fit into this category, but nonetheless, I'd like to cross it off the list of possibilities. So, and then the connection with emphysema. So I'm autoimmune, I have ILD, all right, I'm pre-transplant. And one of the things that I've had is emphysema caused by pneumomediastinum. Is there any connection there? When you talk about emphysema with this condition, is there any connection between that?
So just as we'll often say, this is not to offer medical advice, just general information. Yes, but there is no, so idiopathic or pulmonary fibrosis is not tied to alpha-1 antitrypsin directly. People can have fibrotic disease, so scarring changes as a result of repeated insults to the lung, but typically it's not a interstitial lung disease or a pulmonary fibrotic disease. Emphysematous changes can happen for other reasons in the lung. You mentioned the pneumomediastinum, or someone who's had a pneumothorax. There is some widening and pulling and traction on the airways from pulmonary fibrosis and interstitial lung diseases that can happen and cause an emphysematous appearance, meaning that it looks like there's more air than spongy lung tissue than should be. It does not rule out a coexistence of more than one thing, but yeah, that's I think the best way I would put it.
Okay, so then aside from pulmonary tests, as far as blood work, this is a specialized test that would be run strictly for this, or does this show up in? I mean, I get labs every 3 months.
It's a special test that can be run on those. When you're going and getting a blood drawn, they can test for the levels of it. Testing for levels has some value because if someone has a deficiency, a severe deficiency, then right away we're going to move to thinking they probably need. So we need to figure out what's their gene abnormality, and do they need therapy based off of just this level, or the abnormality and how they are doing. But if someone has just a genetic abnormality and not a severe deficiency, or let's say you had a cold and so it was falsely elevated, then just the blood test would miss it. The other special test would be looking for the gene if it is a normal or abnormal gene. And those can be kits that, for example, in our office, we will sometimes have them, we'll carry them because the industry Greifels has provided us with some sample kits, but you can also get one by ordering it. And they'll typically be, the testing will be covered by insurance, but again, these are free by the from Greifels, the kits at home, yeah.
Thank
And
you.
that's just a cheek swab. Yes.
I have two questions. It sounds as though the serum test can be false. You can test negative for this, but the only way for an accurate test is through genetic testing. Am I right or wrong?
Yeah, it's nuanced in that, if I look at guidelines, then they don't say specifically you have to do look for the gene, but we're not getting the full benefit of testing if we don't have the gene, because then if the level looks fine, this person still might be a carrier. So if we're interested in getting that, discovering what's going on with the family, is that's not necessarily going to affect you or the person being tested, but it's nice to know. And then there's some genetic counseling that goes into that. And so there's benefit to getting just the blood test, but yes, it doesn't give the full benefit. And when the gene test is done, they'll report a level as well. They'll usually report both. Yeah.
And then the augmentation, is that ongoing or is that a one-time infusion?
It's something that's ongoing.
Okay. Thank you.
Yes.
My partner has shortness of breath when she climbs stairs or lifts, carries anything. She's been to her primary care physician, a pulmonologist, a neurological specialist, and no one could find a reason for that. What's the likelihood that she's been tested for an alpha-1 deficiency?
I'd say the usual route is going to be, like you said, she saw a pulmonologist, amongst other specialists, because the shortness of breath can come from just so many different things. So if pulmonary function testing was done to look for asthma, to look for COPD, interstitial lung disease, other lung diseases, and an obstructive disease is found, then people start to think usually, or if based off of a scan and emphysema seen on a scan, that's when people might, their sensors, their alarm goes off for alpha-1. Maybe not enough, and that includes myself, just all clinicians. So if they didn't see an abnormality, just guessing at the likelihood she's been tested, then if there was no pulmonary disease found, then unlikely that she was tested. And yeah, go ahead, Dr. Ruthman.
Great talk, Dr. Dlewati. One question, I don't know if in your extra education you came across any chatter about updating the guidelines that you cited are from 2003, which is pretty old by medical literature standards, and they seem really restrictive in terms of when treatment should be started. A level of 11 is very low. And absent a level of 11, you have to have demonstrable decline in lung function. I might argue that somebody who has a level of 40, who has radiographic emphysema and a minimal smoking history, needs therapy so that we're not waiting for their lung function to decline. Did you hear anything about hopefully getting updated guidelines for kind of expanding the candidacy pool? And this really probably relates more to insurance coverage than anything else.
That's a yes and yes, in that there's chatter about there being an update to the guidelines. It's not imminent, but what people are doing who deal with this more often. So I can't remember his name off the top of my head, but the one who runs the Alpha-1 program in Chicago, at University of Chicago, Dr. Hogarth. He was able to offer a lot of insight. A couple of the others that were at the most recent conference I went to, and they have different thresholds, and it's more like many things that we should do, where it's based off of our clinical acumen. This person needs it, then they probably, even if they're an SZ or even their level. That 11 apparently comes from, yes, when the heads were getting together as far as who should be covered by insurance, and it was not based off of the best set of data. And so it's certainly not a hard cutoff. And if someone has something higher but abnormal, and you just see that, let's give them augmentation to see how they do, et cetera, then yeah, absolutely.
I think one of the messages for any clinicians who are listening to this would be that those guidelines are very payer centric and not patient centric.
Thank you. I got a question, and this is mostly out of curiosity. Since I went through lung transplant and my journey of pulmonary fibrosis all these years, since 2021, when I was diagnosed, I never heard of the Alpha-1, but I saw the correlation from the Alpha-1 to COPD, pulmonary fibrosis, and all this. Why is it that the doctors never, pulmonologists and the team of transplant doctors don't bring this to the patient to see if they have a deficiency to this, Alpha-1 deficiency, and to see what this might accelerate the progression of the disease or anything like that?
If I want to give the benefit of a doubt to the transplant physicians, it should be included in the set of things that are being done pre-transplant and testing people for. Once someone has reached the point of needing a lung transplant, then augmentation is usually not going to alter their personal lung or their personal disease course, but still might have the implications for their family. But there are cases of people who don't get tested, or they don't get tested after they've received their transplant. So, sometimes if something is normal, then it might not be mentioned to the patient. But I think the more we talk about everything we're testing and the implications of it, then the better job that we're doing, even if it's something normal. Just, hey, we ran this genetic test and it's normal, or it's slightly abnormal, you're a carrier, then hopefully, we do a better job of mentioning those things. And hopefully we're always testing for it as well, especially as we're looking at people who need a transplant.
What is the initial test that they might run to either rule it out or say, okay, this needs deeper investigation?
Yeah.
What is that test
blood
called?
or genetic testing.
Sorry?
Either the blood test or the genetic test are what they're going to
Yeah, what
usually
would the-
first run. And with pre-transplant, the genetic test is often done.
Okay, what's the specific name of it? I mean,
There's
so I went through kind of this is 2 years ago. I went through a 2-week boot camp up at Mayo, basically, where they test you every day for 2 weeks to see if they're going to take you into the program or not. So I'm sure that it was run. I just want to look through my history to see what it was. So what test am I looking for?
you might see if you're looking through doctor notes, then if they're putting in what level they got, they might put this
It'll be-
PIMM or PIMZ, a PI something is
Okay.
one way people might put it in, or they might say Alpha-1 or AAT. The test itself, if you're looking for a document that was sent back from the testing agency, then Alpha ID might
Okay,
be one
so
you
all
see.
the tests are in my portal. Okay, so I can look at any blood work, any pulmonary function, whatever. So something with a PI.
It should say Alpha-1 or AAT.
Okay.
Yeah.
Okay.
Yeah.
Thank you.
Do you know the cost of like getting it tested? 'Cause I know some of the lab tests can get crazy priced.
To patients, it should not, especially if we're doing these kits. The blood test, if there's some obstructive pulmonary disease, I don't know how much they're billing, to insurance, et cetera. And let's say if insurance did not, for whatever reason, cover it, I don't know.
I was just curious.
Mhm.
I have one other question.
Yeah.
The frequency of testing, you said that there can be a false positive if there's an infection going on. which I'm sure they would determine by probably an increase
There
in
there
white
can
cells.
be, yes, it could look falsely normal. So
Right.
missing an abnormality.
So would they wait until, I mean, like the white cells are going to be elevated, they're going to wait until the infection is over and retest?
Yes, if you're looking for an abnormal level, you can look for the gene earlier on, or sorry, you can look for the gene when someone is sick. One caveat can be if someone has received some like a blood transfusion, the gene from a buccal swab should be fine. But if they do this phenotyping, if we get more to some of the other ways, the gene should be fine if they do
Okay.
just that's going to be reflecting your own cells and all.
Mhm.
But if they were doing this protein and looking at it in the blood and they just had a blood transfusion, then maybe they're seeing protein from someone else. And again, another abnormality would be looking for just the levels, and the levels are high because it's responding to an infection. A gene, just the gene will be accurate even if someone is sick.
Okay, thank you.
Yeah, you're welcome.
One last question that I got, and it's in reference to the question, going back to the question that she asked. So if the person have any, just a regular cold or any infection or any other issue that elevate the white cells, the white count, that will increase on this test, the Alpha-1, it will just go positive or negative on that one because of the white blood cells?
It's also a number, just like the white blood cells might go from a normal of an 8 to a 16. The Alpha-1 might go, if someone has a normal Alpha-1 antitrypsin, then their normal might be 120 and it goes up to 200. But if someone has an abnormal and their normal, their usual level is a 30, it's showing up now as a 90 because they have that infection. Does that make sense?
Yes.
So yeah, there is a number that's, and that number is what could be misleading.
Anybody else have any more questions?
Yes, I often ask my oncologist, like a lot of these symptoms and troubles I had with the COPD was I have an autoimmune type of blood cancer. And it took them more than a year to diagnose what it was, myelodysplastica. And I said, are these treatments causing, because it seemed like everything came at me in like 2024, shortness of breath. Never had that before. I mean, I've never smoked. I considered myself really healthy, but it seemed like, oh my God, I'm turning to dust. I'm just going to nothing. Nothing is working. And they told me, oh, liver this, kidneys that. Oh, there's nodules on your lung. I said, where is this crap coming from? Is it coming from that blood cancer? And my oncologist says, no, she doesn't want to have anything to do with it. I said, no, it doesn't. But meantime, the pulmonologist is telling me all these other different things. And I said, just figure it out so I can get better. I just want to get better. And I'm confused. Like, I don't know, why this happened to me, but hey, the wheel turns, it's your turn. It's like, it's not why me, obviously it's my turn to take it. So I'm going to take it, but I just want to get better. And I'm doing everything I can through the pulmonary rehab club and through my diet and my exercise, I mean, everything. But somehow these things are connected, obviously, with the bad blood and the COPD. And when they tell me about the liver, I think, well, I'm not even a drinker. Where is this coming from? You don't know.
Yeah.
I mean, obviously. So I'm kind of blaming it on that bad blood.
I mean, the frustration you express is just all too common, and unfortunately, there's just too much separation, and you're hearing such a focus on one thing from one, and on the other, and not necessarily hearing where the connection is coming from. Meanwhile, you just feel crappy, and my father-in-law was sick just a couple of days ago, and he was saying, all right, is it is it chest pain, or is it shortness of breath, or is it, this or that? I don't know. I just felt like I was going to die, so sometimes it's not going to be something we're able to pinpoint from a symptom. And as we get more knowledge, and hopefully you find that happen for you, is that if there is something that unifies it all, that you hear that back, is that, well, yes, as a result of, and this is, for example, as a result of the myelodysplastic syndrome, or as a result of so-and-so, there is some loss of immune, the effectiveness of your immune system, and therefore ABC. Hopefully you can get some clarity towards that, because it's very frustrating.
Thank you.
You're welcome. Yeah, and I'm glad you're doing your part, and the not letting that hamper you from getting to rehabilitation and to what you can do. Yeah.
I might interject. If I heard you say you have unexplained liver disease and COPD having never smoked, you should be tested for this.
The AAT?
Mhm.
Alpha-1.
Yeah. Certainly.
In all fairness, I was tested for Alpha-1, by my pulmonologist, even the bad one that I had.
Good. Good. All right.
It makes it great.
It's interesting. There's a couple of studies that suggest if we test people, even if they're totally normal, but if they're smokers, then they're more likely to stop smoking if you test them, because it's just one more thing that'll cause us to have more counseling with the patient. Hey, I'm testing for something genetic that predisposes, right? Instead of all of it being the blame of, you smoked, you have this disease, you're smoking, stop smoking, but just looking at things more holistically, talking more rather than just
Good common sense.
yeah.
So you probably covered this, but I'm just curious that we all have complicated situations. So when we're going through the diagnosis, so mine, to really land on my diagnosis, it took me over 2 years, okay? Because it's complicated and a lot of things present the same way, right? When is Alpha-1, this testing, is it normal protocol when you get somebody with COPD or any of these other lung diseases? Is it normal protocol as you're trying to diagnose them? Or is it based on the doc saying, hey, this looks like something that we need to investigate? How does that work?
So at the end of the day, the clinician and the healthcare system that they are functioning in determine what's their protocol. So we might protocolize within our clinic that anyone who gets abnormal pulmonary function tests that show an obstructive disease should get testing.
Okay.
I might know that or have that in a note for myself. It's included, in the guidelines to test A, B, and C type of people. But there's nothing protocolized that's going to automatically do it unless you have integrated that into your healthcare system, your medical record system, something that is going to trigger an alarm so it is largely driven by the clinician and the healthcare system they're functioning in.
Okay.
Mhm.
So do you do it at NCH?
We do it. We are working on protocolizing things more, but
Yeah, because NCH is my local pulmonary.
yeah.
So, okay, fair enough. I don't think I have it, but I mean, it's good to know that you guys, that fits into your normal MO.
Mhm.
So, okay, thank you.
Thank you. All right, thank you so much for having me.
Thank you very much to everybody that attended the meeting. Doctor, thank you very much.
Sure.
I really
Thank you.
appreciate
So
it.
nice to
We
meet you.
honestly appreciate this information. Is very helpful to all of us. Something that, like I said, I didn't even know. So I'm pretty sure that I'm gonna look back again throughout all the recording to get all the information and assimilate more of the information. Thank you so much.
What is?